welcome to the NIHR Improvement Science Snapshot. My name is Dr. Andrea Patey, and I'm a Senior Research Associate at the Ottawa Hospital Research Institute and an Adjunct Professor at the School of Epidemiology and Public Health, University of Ottawa, and the School of Rehabilitation Therapy, Queen's University in Canada. I'm delighted to be here to provide an overview of de-implementation of low-value care, what it actually means, and what we know about it. So what is de-implementation? De-implementation is defined as the removal of medical interventions that do not appear to provide optimal care to the population and setting in which they're delivered. So how does that differ from implementation? Implementation is defined as the use of strategies to introduce or change evidence-based health interventions within specific settings. So implementation is about increasing appropriate care or doing high-value care. De-implementation is about decreasing inappropriate or stop doing low-value care. Now that we know what de-implementation means, the next thing you may be wondering is why is everyone so interested in de-implementation? Well, there's a gap in the care that people receive. In fact, 20 to 25% of the care provided is not required or potentially harmful. These harms can include direct and indirect patient harms, unnecessary workload for hard-pressed healthcare professionals, wasted healthcare resources, and negative impacts on the climate. There are limited resources that are not being used for patients who need them. The bottom line is people are not receiving the best possible care that they can receive. Recently, there's been a bit of work to try to understand what it means to de-implement. Over the last decade, some of that work has involved an increasing global recognition of the existence of low-value care and its negative consequences. Organizations like Choosing Wisely promote discussions between physicians and patients about the appropriate care. There are deprescribing networks such as deprescribing.org and the US Deprescribing Research Network, which are interested in reducing unnecessary medications and are concerned about polypharmacy. Organizations like Cochrane, Sustainable Healthcare, and BMJ's Too Much Medicine promote resource stewardship and appropriateness of healthcare. With all this activity, what do we know about de-implementation? If we look at clinical practice as a set of behaviors, whether using new guidelines, performing a surgical technique, prescribing medications, or providing support or advice to a patient, then encouraging appropriate practice is about supporting behavior change. And this framing allows us to use the behavioral sciences or psychology to understand de-implementation, because basically we're just trying to get people to stop doing stuff. So if we think about changing clinical practice as changing behavior and de-implementation as decreasing behavior, do behavioral theories mention de-implementation? And the answer to that is yes-ish. A review of literature found one theory explicitly proposed different strategies for implementation and de-implementation, and that's operant learning theory, which proposes that if you provide reinforcement or a positive outcome when a behavior is performed, you increase the likelihood of that happening again. And if you provide a punishment or negative outcome when a behavior is performed, you decrease the likelihood of that happening again. However, most behavioral theories don't explicitly propose different strategies for implementation and de-implementation, but they do suggest using theories along with a strategy of substituting a different behavior in to decrease the likelihood of doing the unwanted behavior. So we have the idea of punishment in operant learning theory and perhaps behavioral substitution as a potential strategy to use with theory. One thing we need to remember is that while the term may be relatively new, developed since 2012, de-implementation interventions are not novel concepts created in 2012. They have been termed quality improvement interventions, infectious disease control, and then health behaviors like smoking cessation or eating less fatty foods. So the next question is how have people designed de-implementation interventions? And are they already being designed differently? The answer to that question is maybe. A review of existing trials compare the strategies used in implementation and de-implementation interventions. And while there's a lot on the screen, the important thing to note is that there were 3 strategies that were more frequently used for de-implementation than implementation. Specifically, restructuring a social environment, monitoring behavior without feedback, and behavioral substitution, which we heard about in the review I mentioned. So there may be some differences between strategies used in implementation and de-implementation interventions, but it's not entirely clear which ones are most effective and how best to use them. So where do we go from here? You probably can tell from my talk that we don't know a whole lot about de-implementation, but we know more than we did before. So don't get discouraged. All is not lost. While behavioral theories provide little insight into any distinction between implementation and de-implementation, we do know that operant learning may be an option. We just now need to understand how to best deliver strategies from operant learning to decrease or remove suboptimal care. We also know that behavioral substitution may be a useful strategy in de-implementation interventions, but how do we know when best to use it, and how do we pick a substitute behavior? Honestly, I think we're just getting started, and there are lots of opportunities to learn more about de-implementation and improve care delivery. And I hope you found this talk useful.